Bruce, and welcome everybody to the first lecture this afternoon. So, as Bruce has said, what the first webinar is going to be about is evidence-based medication and the rational use of cardiac medications in practice. So the reason that we picked this topic was that when I first started talking to Anthony about this webinar, he was asking me what I thought about the use of various different medications that have more recently become popular in cardiac disease in dogs and cats. So I thought it would be a good idea to get everybody familiar with those medications. And I think it's very easy when you're in practice. There's lots of drug companies come to you and tell you how wonderful their drug is and why you should be using their drug. And it's a really good idea to have an understanding of the evidence behind those medications and the reasons that we use those medications so that you can make a logical choice for your patient and for your client as well. And there's a little added extra to the title today, the use of acronyms in cardiology, because as you'll see as we go along, cardiologists in particular seem to love acronyms. So there's plenty of them in the presentation today. So as we've said, the aims of the talk today are to discuss what drugs we should be using in our patients with congestive heart failure and with heart disease prior to congestive heart failure, how we should be using them in the emergency and long-term scenarios, and what difference does it actually make to the patient if we give them these medications. I think most cardiologists today, particularly in the United Kingdom, would say that most dogs in congestive heart failure should be on quadruple therapy. So when we talk about quadruple therapy, we mean the use of furosemide and or other diuretics. We mean the use of an ACE inhibitor, the use of pimobendan, and the use of spironolactone. So we're going to talk about all four of those medications today and discuss the reasons why we use them and why they're beneficial in our patients. Before we start talking about the drugs themselves, I thought it would be a good idea to review the pathophysiology of heart failure, because understanding the pathophysiology helps us to understand why it is that we're using specific drugs. And I know that you'll all have had lectures in vet school about cardiac physiology, which probably went on a lot longer than this presentation. So I'm going to try and do a whistle-stop tour of cardiac pathophysiology in about 5 to 10 minutes. So hopefully it'll work and everybody will get a bit of a refresher. So in this slide, we're talking about the early stages of heart disease when there is the very beginnings of a problem in heart function. So either very early impaired systolic function in dilated cardiomyopathy, for example, or a small amount of mitral regurgitation in myxomatous mitral valve disease. Impaired function of the heart results in a very tiny reduction in cardiac output at the very beginning of disease. And that reduction of cardiac output is very carefully monitored in the body by the baroreceptors in the aortic arch and by the juxtaglomerular apparatus in the kidneys. So these two areas sense reduced blood pressure and counteract that by various compensatory mechanisms. So the aim of the body is ultimately to maintain blood pressure in a dog with heart disease or a cat with heart disease. And it does this by increasing heart rate, increasing the contractility of the heart, increasing sodium and water reabsorption to maintain circulating volume, and by causing vasoconstriction. So we'll look at these in a little bit more detail. The baroreceptors are part of the sympathetic nervous system, or at least part of the autonomic nervous system. So a reduction in firing of the baroreceptors associated with that very slight drop in blood pressure will result in stimulation of the sympathetic nervous system. And the sympathetic nervous system has widely varying effects throughout the body, but cardiovascularly it causes vasoconstriction and also increases the contractility of the heart as well as increasing heart rate. And all of those together will ultimately result in normalization of blood pressure. The juxtaglomerular apparatus is associated with the renin-angiotensin-aldosterone system. And it's angiotensin II that is probably the most important hormone in this system in terms of the cardiovascular system. Angiotensin II has a wide variety of effects, including direct vasoconstriction, and it also augments the sympathetic nervous system so that all of the other things that the sympathetic nervous system are doing, it also is stimulating. Angiotensin II is very important for cardiac remodeling. And when we say cardiac remodeling, we mean all the changes that occur in the cardiomyocytes when the heart is diseased over time. And that includes things like myocardial fibrosis. Angiotensin II also stimulates aldosterone, which is also a very important hormone when it comes to cardiac remodeling, but it's aldosterone that stimulates sodium and water retention in the kidney and therefore increases circulating volume. In prolonged stimulation of the renin-angiotensin-aldosterone system, you get vasopressin release as well, and that is a potent vasoconstrictor and also causes pure water reabsorption from the collecting duct of the kidney. All of these mechanisms are trying to maintain blood pressure, and the renin-angiotensin-aldosterone system is also increasing circulating volume. If you remember back to the dark days of physiology in university, you'll remember the Frank Starling's law of the heart states that if you increase the preload on the heart, then you increase stroke volume by increasing contractility. So preload is a term that sometimes confuses people, but the way that I think about it is the pressure in the heart at the end of diastole. So when the heart is at its fullest, it's the pressure at the end of diastole. So that's associated with the volume that's in the heart. So if you increase the volume returning to the heart, you increase the preload to the heart, and therefore you increase contractility and stroke volume, as is shown in the curve on the left-hand side of this slide. The problem with these mechanisms is that they're really useful to us in the emergency situation. So the sympathetic nervous system and the RAS system keep us alive when, for example, we have a massive hemorrhage or we're hypovolemic for another reason, and they're also there to compensate for reductions in cardiac output. The problems arise when those compensatory mechanisms are not enough to stop progression of the heart disease, and so the chronic stimulation of these systems becomes detrimental. Chronic sympathetic stimulation is actually directly toxic to cardiac myocytes and also predisposes to arrhythmias. The prolonged increase in vasoconstriction that we see with sympathetic stimulation and RAS stimulation increases the afterload on the heart. Increasing the afterload means that the heart has to do more work to pump out the same stroke volume. So it means that the demand on the heart is greater. The RAS system also will continue to increase the circulating volume, and as we'll see a little bit later, it's that increase in volume that eventually results in congestion. And the RAS system, obviously we've talked about, produces significant myocardial and vascular remodeling. So here's just a schematic of what happens in heart failure. We've talked about the right-hand side of this cycle. So you get this reduction in cardiac output and stimulation of compensatory mechanisms. What happens is that that causes problems with the heart even further. So you get an increase in myocardial oxygen demand. When you increase the volume at the end of diastole, the heart begins to stretch and get bigger to fill up with that increased circulating volume. And having a stretched and rounded heart wall means that there's increased wall stress, which is also detrimental to heart function. You have got maintenance of cardiac output and blood pressure at this stage, but you get further myocardial cell death, myocardial fibrosis, and further impairment of systolic function or impairment of valvular function as well. So you also get continued deterioration of the valve leaflets, continued myxomatous degeneration in that condition. As probably everybody knows, there are two different sort of types of heart failure. And the one that we deal with most commonly in our small animal patients is congestive or backward heart failure. And this is what we talk about when there is an increase in the hydrostatic pressure in the heart. So if you imagine all that excess blood coming back to the heart because you've got an increase in circulating volume, that increases left ventricular pressure, eventually left atrial pressure rises, and pulmonary venous pressure rises, and pulmonary capillary pressure rises. And when you have an increase in capillary pressure, that means that it's less likely that fluid is going to be reabsorbed from the tissue, and you get development of pulmonary edema. The same happens in right-sided heart failure, where you get increases in pressures in the right side of the heart and development of ascites. Forward heart failure is actually relatively uncommon in our small animal patients, but we do sometimes see this in particularly severely affected dilated cardiomyopathy dogs And also we sometimes see it in cats with hypertrophic and hypertrophic obstructive cardiomyopathy. Forward